Welcome back to the Deep Dive. Today we're unpacking what might be the single most data-dense appointment in early pregnancy, the first trimester screening. We're talking about that really short window, usually between 11 and, 14 weeks of gestation?
That's right. It's a tiny window, but the amount of critical information they can pack into it is, well, it's astounding.
It really is, from just confirming viability all the way to assessing, future obstetric risks.
It's a feat of integrated medicine. And when we talk about the screening, we're really focusing on an optimal window for the scan.
Right.
The source material actually defines it by the fetus's size, a crown rump length, or CRL, between 45 and 84 millimeters.
So it's not just about the weeks, it's about the actual size.
Exactly. That time frame, generally 13 weeks and 6 days or less, is when the accuracy just peaks, and crucially, when clinical interventions can be most effective.
That's the challenge, right? Trying to maximize accuracy while the anatomy is still so small. So when a specialist sits down for this first trimester ultrasound, what are the non-negotiable core objectives they have to hit?
Okay, so there are 5 foundational pillars. First, you have to confirm the pregnancy even exists by identifying cardiac activity.
Okay.
Second, establish an accurate gestational age. That drives literally all subsequent care.
Got it.
Third, confirm it's in the right location. Fourth, how many are there? Are we talking twins or more?
Right.
And then fifth, and this is maybe the most complex part, is using that early view to screen for potential anatomical problems, chromosomal risks, and complications like preeclampsia.
Let's start with the absolute basics then, confirming that foundation. You mentioned viability and location. I noticed the source material is, really pedantic about terminology here.
It is.
Specifically insisting on cardiac activity, not heartbeat.
It is, yeah. The Society of Radiologists in Ultrasound specifies using cardiac activity because the structure is just so immature at this stage. It's all about being clinically precise.
So confirming that movement is step one.
Step one, and hand in hand with that is checking the location. Is it an intrauterine pregnancy, an IUP?
And if it's not an IUP, that could mean an ectopic pregnancy. Most people think of that as, a tubal pregnancy.
Yeah.
But that definition has gotten a lot broader, hasn't it?
It has, significantly. The source clarifies that an ectopic pregnancy is any pregnancy implanted in an abnormal location.
Any.
And crucially, this includes implants that are inside the uterus, but in a, let's say, a compromised spot, like a cesarean scar.
Wow.
Yeah. And identifying those abnormal sites early is just absolutely vital for the health of the pregnant person.
Okay, so dating. Everyone has their apps. They know their last menstrual period. But the CRL measurement still seems to rule the day. Why is a machine measurement still the gold standard?
It's a great question. It's because the crown rump length, that measurement from the top of the head to the bottom of the spine, is the single most accurate predictor of gestational age in that first trimester.
More than known dates.
Far more. Embryological growth is just highly standardized during this period. So an accurate CRL measurement is much less variable than relying on history. Establishing that date early on locks in the timeline for everything else.
Speaking of technical details, the material notes that a transvaginal approach should always be available, even if they start with an abdominal scan. Why is that so necessary?
It's all about resolution.
Okay.
Especially when you move from just dating to the detailed anatomical assessment. If the abdominal view is obscured, say, by a high BMI, or if the uterus is retroverted, tilted back,
Right.
a transvaginal scan just gives you that superior high-resolution view you need to accurately assess these tiny, tiny structures and markers. They're critical for the screening.
That makes a lot of sense. You need a backup plan if the standard approach isn't giving you a clear enough picture.
Precisely. And just to finish on that foundational talk, the terminology, we are dealing with a fetus here. The standardized rule is embryo up to 10 weeks and 6 days.
And then fetus from 11 weeks onward.
Exactly.
Okay, let's shift now to the really complex part, the anatomical checklist. We're looking for structural anomalies in an organism that's, the size of a lemon?
Yeah, and this is where the skill of the operator is absolutely paramount. The sources really emphasize that your detection success relies heavily on using standardized protocols and, skilled hands.
You can't just do a quick peek.
No, if you do that, your detection rates just plummet. Formal screening protocols are essential.
So let's walk through the must-haves, the minimum checklist for that 11 to 14-week scan. When you're looking at the head and the brain, what are the technical things they're scanning for?
Okay, so you need an axial view showing the falx cerebri.
The falx cerebri.
That's the vertical fold that separates the brain hemispheres. And what's fascinating here is what they call the butterfly sign.
The butterfly sign.
Yeah, it's where the choroid plexuses look like they almost fill the lateral ventricles. Seeing those two things tells us the brain is developing symmetrically and it's filling the skull like it should.
Okay, and moving down the body from there.
For the neck, we have to confirm the neutral translucency, or NT, thickness is below the 95th percentile. For the body, the heart has to be inside the chest, beating regularly.
Which you check with that four-chamber view.
Exactly, an axial four-chamber view. We also need to see the stomach bubble and the bladder, make sure it's there but not, dilated, and confirm the abdominal wall is intact.
And the limbs.
All 4 limbs must be visualized. And you have to confirm they each have 3 segments, upper arm, forearm, hand, and so on. That's the basic scan every center should be able to do.
Now, if you have a highly skilled operator, they can perform a much more detailed anomaly scan, right? Taking this check much further.
Yeah, and this is really considered best practice. A great example is the posterior fossa assessment. Here we're looking for something called the intracranial translucency, or IT,
The IT.
which corresponds to the 4th ventricle. And why is this so important? Because routine visualization of the IT significantly improved detection rates for open neural tube defects.
Those spina bifida.
Specifically spina bifida. We're essentially looking for indirect markers of a problem with spinal development much, much earlier than we used to.
That's a powerful screening test.
Ah,
The profile view of the face is also really relevant here, I take it.
absolutely. We look at the nasal bone, the NB. A missing or hypoplastic, meaning small nasal bone, is a key marker linked to both structural issues and trisomies.
Yeah, and the heart.
For the heart, a detailed scan can bring in Doppler analysis of the outflow tracts and the 3-vessel trachea view. You're looking for very early signs of major cardiac abnormalities.
Okay, so here's a crucial reality check. You've just listed all these incredibly detailed anatomical points, yet the overall pooled sensitivity for catching major defects isn't anywhere near 100%.
No, it's not. The combined detection rate sits just shy of 70%, 67.33% to be exact. Though we are fantastic at ruling things out, the specificity is near 100%. But yeah, that pooled sensitivity, it varies dramatically by the condition.
Give us an example of that variability.
Okay, so for massive defects like acrania, where the skull is missing, or gastroschisis, where the bowel is protruding,
Right.
detection rates are excellent. We're talking 96 to 98%. But for defects that either develop later or are just more subtle, the numbers drop. Open spina bifida is potentially detectable at 69%, but if you look at talipes or clubfoot,
Yeah.
detection is only around 11%.
Wow, 11%. That's a really stark reminder that this scan is a screening tool, not some kind of definitive diagnostic finale.
Exactly. It dictates the need for that follow-up scan in the 2nd trimester. But, catching 2/3 of the major issues this early allows for critical early counseling and planning.
Let's talk about integrating all this, specifically with genetics. When people think of risk, a lot of them immediately jump to chromosomal issues like Down syndrome. But the source data makes it abundantly clear that structural anomalies are far, far more common.
That's maybe the single most important statistical takeaway here. Anatomical defects occur at about 222 per 10,000 pregnancies,
Okay.
whereas chromosomal abnormalities occur at about 36 per 10,000. Anatomical problems are nearly 7 times more frequent.
So if the odds are so heavily skewed towards structural problems, does that fundamentally change how we should be counseling women, even those who might have a really reassuring NIPT result?
It absolutely should, because the majority of perinatally relevant issues are structural, not genetic. And that's why the first-trimester ultrasound is, well, it's irreplaceable.
So how does the traditional combined first-trimester screening, the cFTS, handle the genetic side of things?
cFTS is the standard algorithm. It calculates an individual risk score by integrating 4 pieces of information.
4 pieces.
Right. The person's maternal age and gestational age, the fetal neutral translucency thickness from the ultrasound, and then 2 markers from maternal serum, biochemistry-free beta-HCG, and PPA.
And what's the performance of that algorithm like? Is it good?
It's very high quality. The detection rate for trisomy 21, Down syndrome, it ranges from 87% up to over 92%, with a pretty low false positive rate of around 5%.
Interesting.
Yeah, if a fetus has trisomy 21, the serum profile is pretty characteristic. You get high free beta-HCG and low PPPA.
And those ultrasound markers, the NT, the nasal-borne, they aren't just for anatomy. They're deeply integrated into that genetic risk calculation.
They are crucial indirect screeners. A thickened NT is a massive red flag.
Right.
It's associated with trisomies 21, 18, and 13, and with structural defects. I mean, you can find a major cardiac abnormality in up to 40% of those cases.
40%.
Yeah. And then the absence of the nasal bone, or abnormal flow in the ductus venosus, or tricuspid valve regurgitation. All of these things significantly amplify the suspicion for aneuploidy.
Okay, now let's bring in the modern powerhouse, an NIPT. Non-invasive prenatal testing, we know this is incredibly accurate for trisomy 21.
It is the best screening method for the common trisomies, full stop. The detection rates are phenomenal, around 99%, with a tiny false positive rate, often less than 0.05%.
But this leads to this central, unavoidable question then. If NIPT is so good at catching chromosomal issues, why do we still need the detailed first-trimester ultrasound?
Because NIPT screens only for chromosomal abnormalities. It provides zero information about the structural development of the fetus.
Right, we just established structural issues are way more common.
Exactly. If a patient skipped the ultrasound relying only on NIPT, they could delay the diagnosis of a severe birth defect until the second trimester scan, and you lose crucial time for counseling and management.
So the ultrasound really leads the clinical management decision. Tell us about that integration rule.
So if the ultrasound identifies a major structural anomaly, or if that NT thickness is significantly increased, say 3.5 millimeters or higher, the clinical path changes immediately.
Immediately.
The source material is explicit. In these cases, you indicate immediate invasive diagnostic testing, like a CVS or an amnio, instead of NIPT.
Why instead of?
Because these dramatic findings suggest a complex chromosomal or genetic disorder that standard NIPT panels just don't cover. The abnormality you can see on the screen becomes the top priority.
That brings us to our final and I think often most overlooked section.
Yeah.
The preventative screen. The ultrasound isn't just about what is wrong, it's about predicting what might go wrong, specifically pre-eclampsia.
This is a major clinical success story, and it's enabled by this early screening. The whole goal is the early prediction of preeclampsia, particularly the preterm forms, because we have a remarkably effective, cheap, and safe preventative strategy.
If you started early enough.
If and only if you started early enough.
So how exactly do they calculate that PE risk in the first trimester? It sounds incredibly sophisticated.
It relies on the Fetal Medicine Foundation, or FMF, algorithm, which needs 4 components. First, maternal factors.
So history.
History, yeah. Previous PE, chronic hypertension, diabetes, a high BMI, those are huge risk multipliers. Second, a biophysical marker, which is the uterine artery pulsatility index, or UTAPI, measured with Doppler.
Which checks blood flow to the placenta.
Exactly, the resistance to flow.
And the other two.
Third are the biochemical markers, placental growth factor, PLGF, and PPPA. Low levels of both suggest placental dysfunction and a higher risk. And finally, the fourth component is mean arterial pressure, or MAP, which has to be measured properly on both arms.
That combined 4-part approach must be very accurate.
It is, especially for the really severe forms of the disease. This combined approach detects 100% of the preeclampsia cases that require delivery before 32 weeks.
100%.
100%, and about 75% of cases needing delivery before 37 weeks, all while keeping a manageable 10% false positive rate.
So you identify the women in that high-risk group, and the clinical imperative is just immediate treatment.
Absolutely. The main driver for doing this screening is the ability to start aspirin prophylaxis. Women who are identified with a PE risk greater than 1 in 100 should immediately start taking aspirin 150 milligrams every evening until 36 weeks.
And the stats on that early intervention are pretty compelling.
They are undeniable. Starting aspirin before 16 weeks reduces the risk of preterm PE by 62%.
Wow.
And for the very severe cases needing delivery before 34 weeks, it reduces the risk by an astonishing 82%. This proactive prevention is one of the strongest justifications for making this screening mandatory.
This deep dive has really clarified that the first trimester screening is so much more than just a dating scan. It's like a whole integrated system. Ultrasound, blood chemistry, maternal history that gives you this foundational risk assessment for anatomy, for genetics, and even for future complications like PE.
It's a foundational risk stratification tool, yes. But we do have to reiterate that a lot of structural conditions only become fully recognizable or even manifest later in the pregnancy.
Which means the FTU is not the finale. It has to be followed by that comprehensive fetal anomaly screening in the second trimester.
Correct. The early diagnosis gives you time for counseling, for genetic management, and for that preventative action we just talked about.
But, in the rush to diagnose early and intervene, there's a critical psychological consequence we have to account for. The sources stress that women must be counseled on the emotional side of finding results that are a cause for concern. Things like certain omphalocele or maybe a mild bladder dilation, things that might actually resolve on their own later.
That anxiety is a real clinical consequence. The anxiety caused by early detection, even of these transient findings. We are providing earlier and earlier access to data, but we have to ensure we provide the corresponding emotional and psychological support.
It's a key part of the care.
It has to be. The goal is informed decision-making, not just early detection. And that means managing the anxiety that is just inherent in finding possible risks this early.
A vital perspective as this technology continues to get better and better.